Hello, good day, and welcome to this third webinar of the EHDEN project. My name is Kees van Bokhoven. I'm from the Hive. We also have two guests with us today, calling in from sunny Catalonia, Talita Duarte Sayes and Leonardo Mendes Bo. Welcome to both of you.
Thank you.
I'm so glad you could join us today to talk about the challenges and also the opportunities for OMOP. And specifically also to look at the role of OMOP in CDAP. We're going to get into a lot of topics today. It will be very multidisciplinary. We will start with the health system in Catalonia, the role of CDAP in this. We'll also have a look at the role of OMOP, CDM, and the EHDEN project. And finally, we'll have some forward-looking statements as usual in this webinar. Just to remind you, this is the third in a series. If you're just joining us for this time, welcome. If you have seen the first ones, welcome back. So the first one was about the study-a-thon that we had in Oxford, where we used several hundred millions of patient records equivalent to answer a clinically relevant question in 5 days. Great webinar. And then the second was from our project leaders from Nigel, Peter Rijnbeek and Nigel Hughes, where they explained the projects, the open calls that we have, and also the vision they have for Europe. So without further ado, I'd like to get into maybe start with your experiences and a little bit about your background. Talita, maybe you can take it away and tell us a little bit more about yourself and your role in CDAP.
An epidemiologist working at EHDEN Webinar, which is a primary care research institute here in Barcelona, in Spain. I've been working here for the last 4 years, mainly involved in projects with using the CDAP database, which I guess we're going to talk a little bit more about in a minute. I've been the scientific coordinator of the database for a while, involved in a couple of IMI projects, including the EMIF projects. And there was when I started to get involved in the mapping of the CDAP to the OMOP common data model. Yeah.
Right. Maybe Leo, you can do the same.
Yes. My name is Leonardo Mendes. I'm working with the Catalan Health Institute from 2006. Mainly, I'm a physician with a specialty in preventive medicine, public health, and epidemiology. So since 2006, I've been working with the Catalan Health Institute in the part of mainly looking to the electronic health record in order to produce clinical quality of care indicators and provide feedback and reminder systems to the GPs in their clinical station. So from 2010, I've been collaborating with CDAP to provide the data, so put it in the format that CDAP uses it for its production.
Right, okay. Let's unpack that a little bit because there's a lot of information there. So effectively, Leo, in a way you work for the government, right?
Yes, Catalan Health Institute is a public enterprise.
And what is the role of the Catalan Health Institute in the health system?
Well, Catalan Health Institute is the main provider of primary care. 80% of the population is covered by our institution, and it also manages 5 of the biggest hospitals in the region.
Yeah, so maybe it's important to say that Spain is divided in 17 autonomous communities. We could share with you our screen where we had a presentation here. Can you see that?
Yes, so I can see it.
Yeah, so we have 17 autonomous communities in Spain. And I think in order to understand what is CDAP, it's important to understand the health system in Spain. And one of the particularities of our health system is that it's a system funded by general taxes, and it has a universal coverage. So everybody living in Spain has the right to healthcare. Is it of free access? But also I think it's important that this decentralization to the regional autonomies. This is very important because this is when the Catalan Health Institute has a big role here in Catalonia, because it's the main health provider here, covering approximately 80% of the population. So here you can see in this this figure here, it's the map of Catalonia, and the areas in white are the areas for which we don't have data in CDAP because they're a different health provider. But as you can see, the majority of Catalonia is covered. Yeah.
Right, so you have actually information about the patients from multiple angles. Do I understand correctly that CDAP focuses only on GPs, or do you also have data from hospitals, other health providers?
We also have data from hospitals. So here you can see a summary of the kind of data that we have. So though the CDAP was created in 2010 by the Catalan Health Institute and EHDEN Webinar, it does include information since 2005, because this is when the health records were informatized in Catalonia. Mainly the information that we have there are coming from primary care. So from this ECAP software, where health professionals can register any kind of information. So all that is included in CDAP, and here you have a list of the things that we have, including diagnosis, prescriptions of drugs, the date of death, information on sick leaves, etc. But we are also linked to other sources of data, such as the official pharmacy invoice database. From here, we can get the information on the drugs that are dispensed in the community pharmacies. We are also linked to the primary care lab database. So any tests that are performed in the laboratory, we can have also the results of those tests. We have some indicators of socioeconomic status, and we are also linked to the hospital admissions database, which includes up to 10 diagnoses and 10 procedures which are performed in inpatient care. So that's a summary of all the things that are included in the CDAP.
Okay, so in principle, you track a lot of the patient information and journey as you go through the health system, from the GP through to the hospital. Maybe actually you can comment a little bit on that. So what exactly is the role of the GP in Spain and Catalonia?
Yeah, GPs, they work as a gatekeeper of the health system. So it's very similar to the UK, for example. But they play an important role, not only the GPs, but the health professionals in primary care, the nurses, the pediatric nurses. We also have pediatricians and different health professionals working in primary care. They play an important role and also in the prevention and promotion of health, but also, seeing the patients for the first time and sending them to specialists.
Right.
If you want to add
yes,
anything?
maybe when we get to look at what data in terms of number, for example, we can show that people are starting our database when they are just newborns. Most of the people we get in there, and
Right.
therefore for the rest of the years,
So what about some of the more advanced treatments, like, for example, for cancer? Is that also part of the CDAP database, or are there other sources that you're linking to that have this information?
Yeah, for that specifically, it's not there yet. Hopefully it will be in the future. But for now, we've been able to link to other external databases, such as, for example, we have 2 population cancer registries in Catalonia, one in Girona and one in Tarragona, and we managed to link to those registries in order to perform validation studies. And this is a particularity of CDAP because the database itself is anonymized, but it's the Catalan Health Institute can have access to personal data, so they can link data and then anonymize and send it to CDAP. So that's very, very useful for us in order to link with other data sources.
The Catalan Health Institute is acting as a trusted party to perform the linkages and put the anonymized data in the CDAP database.
Right. Yeah. That's very crucial, and that's different actually in every European country. but let's not get in that today. Maybe one of the future webinars we can spend some proper time on that, because it's a very complex topic. But what I would like to explore with you before we dive deeper into OMOP and the relation to OMOP CDM is how the data that you have in CDM is used today. So can you talk a little bit about, you have this fantastic collection, very rich, very standardized. Who's using that and for what purpose?
So most of the studies performed now with the CDAP database are performed by researchers at EHDEN Webinar. So we have different research groups working here. Some of them are specialized in diabetes, cardiovascular disease, musculoskeletal disorders, cancer, among other things. But then we also can give data to other public institutes in Spain to work with the data. And also some pharmaceutical companies are also interested in the data, and we have had collaboration with this in the past. And the type of study are mostly so pharmacoepi studies, clinical and drug characterization studies, association studies. We've been able recently to link with urban environment data. So there's a lot of possibilities of studies that are going on right now with CDAP. We've also been involved in some projects and also a lot of safety studies and the post-authorization safety studies for the EMI, for example.
Right. So can you maybe explain a little bit about the topics, or so what are some of the questions that you could answer using this data? And maybe towards the end of the webinar, we have time to dive into it deeper. But just for now, can you give us an overview of what are some of the example research questions that the researchers could be working on?
Yeah, I can mention some of the projects that I'm involved. That's easier for me. But for example, we have this project to study the relationship between obesity and cancer, and looking at different comorbidities and how those can affect this association. We also have a study looking at the association between childhood obesity and urban environment here in Catalonia. So, as I said, we were able to link the CDAP data to urban environments such as like air pollution, walkability index in the cities, and that's a very interesting project. We also have different projects now in collaboration with Dani on musculoskeletal disorders and cancer relationship. But then also we do perform studies such as like validation studies to make sure the data we have is of quality. I think this is very important because what we have is a lot of data, and we want to make sure that this data is reliable and quality information, right, for research, and that's what we've been working on. Another interesting study that we've been working on was to link parent and child within the database, and that was a project that we did in collaboration with the Catalan Health Institute again, and it was very, very interesting, to have more than 500,000 children linked to their mothers. I think that has a big potential for future research within CDAP. So yeah, those are kind of examples of the things we've been doing.
I think there was one study that was rated as one of the top 10 or top 20 researchers in primary care with CDAP data.
Right.
Yeah, that was a study on statins and cardiovascular disease and mortality that was published last year. I think that was a very interesting study as well. Yeah.
Right. I'm just getting a note from the tech team here asking you if you could get on the camera. But I would also like to take this opportunity to progress to the next topic, which is really about how can CDAP be assisted and helped in your day-to-day business as you're doing these studies by OMOP, by the OMOP CDM, and also by the EHDEN project. And maybe to start that off, we could dive a little bit deeper into the sort of data flow, if you will, of CDAP. So what actually happens when a researcher comes to you with a project or when you're doing an internal research project? Could you tell a little bit about the stages that are involved?
Yeah, sorry, I need to share my screen again. Sorry about the PowerPoint things, but I think this is a nice, it represents very well the project flow of CDAP. So first of all, a research team usually contacts CDAP in order to see if the project is feasible or not, if they can do this study with the database or not. If the answer is yes, then they have to prepare a study protocol, which will then go through a scientific committee, an ethics committee, and then the researchers have to sign the number of agreements. And after all that, then it gets into what we call the production phase. So it's basically trying to extract from CDAP the specific information needed for that project. There's a lot of work on data management in order to prepare the database for that specific project. And once the database is ready, it's released to the research team, and then they can run the study. Is that clear?
Yeah. To me it is, but that's the situation today. I think this is very common, very typical of how certainly observational research projects are carried today. Maybe you could also dive into how would OMOP, and if all your data were in the OMOP CDM. And by the way, for those viewers that don't have the background on the CDM, I can also recommend you to watch the first webinar with Dani, where we do go into the CDM itself a little bit, and also the second. But here, maybe you could explain OMOP and Odyssey and how your data in OMOP could help this process.
Yes, I think, when I showed you the project flow of CDAP, I think the key points where the Odyssey tools can help us, on our everyday work is, first of all, in the feasibility assessment. Mm-hmm. So clearly, I think we have our own tools that we have developed for that, but now we can start using the Odyssey tools to do that, and I think it's very helpful. Another point is
sorry to interrupt you, but for the viewers that are maybe less familiar with observational research, could you explain what is a feasibility assessment?
Yeah, so basically, when a researcher has a specific research question, you need to make sure that we have the data, that the data is there, and that you can answer that question with the data that we have in the database. So one thing we do is check the number. So check first if that information is there or not, and then check if we have enough number to do the study. And then another thing we like to do is to check then also the quality of that data. So we usually perform validation studies and we have our internal quality control methods to make sure that the information is of quality.
Right, so you sent me this paper last week of one research that was done in CDAP, which was about, does it make sense to give statins to older people, especially people older than 75? That's an example of such a research question. So, but in this case, what exactly would you be looking at with a feasibility assessment? You'd look if you have enough data to answer that question. Is that what a feasibility is about?
Yes, exactly. We check if we
have enough diabetic population represented of the appropriate ages, and if we have the outcome of interest, and if we have the confounding variables with such quality to answer the clinical question.
Right. So this is something that you're doing already a lot today.
Yes.
Why would it be faster or better with OMOP?
I think in that particular area, we do have our own tools that we create to do that. So I don't think it's specifically to help us a lot on that.
But the use, for example, of the vocabularies, the standardized vocabularies, it streamlines the construction of the concepts to look if you have enough of the population. So it's easier if you have a phenotype for diabetes already constructed and you can query that instead of going back to zero and constructing from nothing.
Right. Yeah. I mean, from the EHDEN perspective, the obvious advantage is that we can send you the feasibility question. We can send it to all the data sources in the network and hopefully get some sort of a standardized response back.
Yeah, exactly. I think that's very important, you know, that we will be able to, I think the potential is also for the multi-database studies it's incredible. Yeah, I think I totally agree with that.
Yeah, but even it's very good to hear from you as a data source, just internally on your processes, how you could be helped already. Because, you know, as EHDEN, we have this challenge that we have to convince all our stakeholders to kind of move along, and we want to find the best equilibrium between the interests of all the partners. And I mean, you're not part of EHDEN. You could become a partner by applying for the data grant or by becoming a data partner in the network. But I think part of the reason why we have this interview is to explain and also to find out from you, and maybe also then send that to other data sources, if you will. What is exactly the interest?
Because one of the things we were thinking now in the OMOP CDM is use it as the base of as the core of the CDM database. We have now one way of representing our data, and OMOP is a standardized one. We have seen that it's good enough, so we can at least use it as a base and build from that to represent our complexities in our own database. But we can use the core, and then we can profit better from the tools already designed.
Yeah, we've spent a lot of time creating our own tools, and now that when we see that we have all those tools already available, we can think about the next other things that we could help creating within the community. And also, I think definitely for other databases there are a lot of advantages. So I would totally recommend mapping to the OMOP CDM. Yeah.
Right.
A lot of challenges as well, which I think we'll be talking about a little bit more today.
Yeah. Yeah, so I interrupted you there, Talita, sorry, in your diagram. Do you want to continue, or have we already covered?
Yeah, so I think, when I show you this, let me just share again my screen. When I show you this, the project, I think, one of the things that I think the tools are gonna help us in EHDEN, it's also we do a lot of work on data management. We spend a lot of time, and we have a lot of statisticians working to prepare databases for a specific project. And I think with the Odyssey tools, that will be much faster, definitely. So these are kind of the things that we think that we're going to benefit in the internal, more like an internal way. Also for the study runs, for our own research teams, if they start using the tools, they can already run a study using Atlas, and I think that again will make our research go much faster. So there are a lot of, as you can see, for us, there's a lot of advantages internally in the process of normal project. So obviously we can talk about a little bit more about the benefits, the external benefits, of working in a network with other databases and the benefits for research in general, right?
Right. So to come back on that point on quality, in Odyssey there's a whole working group on data quality and multiple initiatives going on, and it can actually mean different things to different people. So could you explain a little bit more about what quality means for you? Is that to ensure that the data is standardized between GPs, or is about, let's say, is the data actually correct, or what does it mean?
I think there's a lot of things we can, both of us, we can talk a little bit more. There are some very specific things, for example, plausibility. Just checking if values are plausible or not. For BMI, for example, it's part of the work of CDF. Making sure that the information that is there makes sense and is reliable. The correctness of that data, I think people talk a lot about, data, we have more data every day, and just give me the data and I will know what to do with it. I think it's about what I said before, transforming data into reliable information, and that's what we try to do with all these quality controls. We also, for example, we have data coming from different labs in Catalonia, and those labs can use different units. So we have to do a lot of work on harmonization as well. And this is also something that OMOP CDN is going to help us to not have to worry about anymore.
One thing specific of the Catalan data is that in primary care we have in origin like 21 different servers. Even though it's the same software, it's represented different servers. So we have to check if we have data from all of them in the sufficient quantity as expected, and also look at it over time, so we don't have like glitches in the volume of data. And also we go by territory, by physician, calculate the prevalences, if we have enough data mainly.
So there's also a lot of, we perform these validation studies, we want to make sure that the data there it's of quality internally and externally. So for a different number of outcomes, we perform the validation studies as well. Yeah.
Right. So the plausibility of the data, merging data from multiple sources, and then also validating it. I'm listening to how OMOP specifically helps there, and one of the things you mentioned, I think a couple of times, is the standardized vocabularies and also the standardized data model. Mm-hmm. So Leo, when you talk about these various applications, I think you're very lucky, by the way, to have the same software running. Yeah. Because if you look at the Netherlands, for example, there are I think a few dozen different GP primary care health information systems. But even so, you still need to merge data because GP is not that software is not your only data source, as you shown in the beginning. How much is, if you think about the mapping that you did, maybe going into that, how much is it a question of, you have a data model and we just need to standardize to OMOP so that we can actually combine it, versus standardizing the vocabularies? This in OMOP, what we call the syntactic mapping and the semantic mapping, right?
There's both sides of the to need both standardization. One is in the modeling, that means the tables and the columns and the which kind of data you are going to put into the common data model, which that's prescribed by the MOB common data model. And the other one is the vocabulary. So in our case, for example, we have data from hospitals and for primary care. They're using different coding systems for conditions. One uses ICD-9 and primary care uses ICD-10. So up until now, we didn't have that information in the same table. We have to produce the concepts in each of those vocabularies by separate. Just by having those in the same structure and having the semantics, having them mapped to the standard in the OCDM, which is SNOMED, that's a big advantage because you have to define against one common vocabulary in one common structure of data. That's also true for procedures and for other domains.
For drugs as well, right? Because since we have both prescribed and dispensed drugs, for the first time we can have everything in the same place, and I think that's a big advantage as well. Mm-hmm.
Right. So now we're getting, let's say, to the technical details, where you have OMOP. And I think almost the ABC of OMOP is that you have to learn that there are these domains, right? So there's conditions, procedures, drug, etc. Maybe we should talk about these a little bit more in detail. And also, maybe you can use that as a guide to tell us more about what did it actually take to map the data, right? So Leo, you were talking about conditions. Could you tell us a little bit more about the mapping process for conditions, harmonizing that between the various sources from CDF?
Of course. Maybe I can share the screen. The next slide, I think that's, well, we have in several provenance of data in our database. So some codes are international standards, like ICD-10, ICD-9. For those, OMOP already provides the vocabulary and even the relationship to map it to a standard concept. They provide the relation, so you use it to your ETL. We have another kind of data that is local codes or national codes. That for that the Odyssey provides the series of tools which we used. One is the White Rabbit, that's the first one. It profiles you run it against your database, and it profiles it table by table, column by column. So you have numbers of occurrences, and that's very useful in order to decide which codes is you get the best profit to map, because typically there are thousands of codes, and just 20% of the code maybe represent the 80% of the data, and those usually asked for in the studies. So, the counting is very important to decide up to what level you get to map. So we have covered the standard international codes that's provided mapping near MOB CDM. The local codes, we use this. With the coding counts that we produce, how do you change it? Okay. You feed it into the next tool, that's Rabbit in a Hat. With Rabbit in a Hat, you get that information, and it provides the user interface to map each of the source tables to the destination table, and it produces a blueprint of the logic of the ETL. That's very useful. You decide table by table, and also even, for example, gender. It is prescribed which standard coding you use, so you take notes there and get it to produce the ETL.
And if I must say something here, this can look very simple, but I mean, it took us quite a while to get this figure here where we have our source tables and how do we move to the common data model. I think we spent one morning with OMOP experts discussing specific things and making decisions here. So just, I mean, it looks very easy here, but at the end, it's a lot of work. And these decisions here are very important for the future of the projects that we're going to do.
And the next step is to look at the codings. There's the tool, Usagi. Usagi, you give it the source information with the counts, and it proposes your mapping depending on the domain that you are putting that data in. If it's conditions, it proposes you a standard condition for that. If it's drugs, and you can review it and accept it or profile it better. So you get a table that gets from the source code to the target code that you can use in your ETL.
Right. It's great to see that you've been able to use the OMOP open source tools for the mapping. I mean, that's what they're for. What was your experience using these tools? Because you have already mapped, right? Or are you still in the process of mapping? Maybe to clarify.
We have mapped some domains, and some other are still in work in progress measurements. That's mainly because in measurements you don't only have to map the concept of the measurement, you also have to map the values and the units, and it's a categorical value, the concept as a value code. That does take more detail and more dedication. So we have some domains, and some other are missing yet, but we're working on it.
Right. Yeah, so these tools from the Odyssey community, on the one hand, it's nothing special, you could say, because, for example, data profiling tools, there are a lot of data profiling tools, open source, commercial, etc. But I think what makes them unique is that they are specifically designed, created, just almost grassroots, if you will, with OMOP Odyssey in mind. And you can see this very well in a tool like Usagi. However, it's certainly not commercial software, which is just, you know, one-click install and everything is fully documented. You have to dig a little bit into it and sort of get a hang of what these tools mean, what they do. And how was that for you? What's the learning curve?
We have some help because we were assisted by Peter Reinsbeek and by Michel from Janssen. So they got here. We have a workshop. They presented the tools, and we do the installation. You can follow the documentation, and it depends on the proficiency you have with this kind of open source tools. But we are in CDM, we're using open source tools from the very beginning, and they were very useful.
Yeah, but the help from OMOP experts was really the key, and I think here's where I think within EHDEN you have the SMEs, and they will have an important role. For the database, what I would say is that you should definitely ask for help when needed, because I mean in our case, Peter and Michel were helping us quite a lot on this process. And one of the things I like from EHDEN is that there's also a part focused on the education. And I think it's important, all the training, you know, you need to do that so people can use these tools. And I think that's very important.
Let's not forget the community, because you can ask the questions and you're promptly responded by many people that are willing to help you. For instance, we had to do optimization for the profiling because it was taking long, but you ask to the community, they can say you how can you increase the memory use, and it's very useful.
Yeah, the forums are very useful as well. Yeah, people are very engaged and they participate quite a lot in the forums, and that's really nice.
Yeah, I can only confirm that I think the people in the Odyssey community and also in EHDEN have an enormous passion for working with health data and standardizing that. And we certainly have plans to also improve on and expand on these tools, but we want to do it in a way which really helps, for example, you as a data source forward, and also helps the field forward in terms of doing observational research. So it's very good to hear from you that you had good support, and for the coming years we're definitely committed to keep that up and even make better tools. We have the whole EHDEN Academy. Yeah, you've worked with.
They are working now, I think, in a project that's called the Book of Odyssey, that I think is going to document the whole tools and the processes. So it will be a big help.
Yes. Is there anything else that you want to share on sort of your learnings, or other ways maybe we can also go into what are really the benefits now? Can you already, even though you're still in the process of mapping, but can you already share some insights, new ideas, new realizations that you got from working with OMOP?
Yes, so that's like where we are on the mapping process of what we have planned. No? So as of now, we have realized the power of the vocabulary as of itself is a powerful tool, as we mentioned, to produce the concepts, to create criteria, to build cohorts. It's like in there, vocabularies help a lot. The other is the CDM as of itself, just by putting the same kind of data that comes from different provenance in the same structure, and also using the same vocabulary, that facilitates a lot of process. The other was deploying the Atlas tool, which is like a portal where many of the Odyssey tools can be launched from. So you can look at your data, it generates reports, it generates quality checks.
If I must say, I think that's very important, because for the quality checks, I think we realized some things that were not correct in our database when we used this. So for example, we saw that there were some dead people with conditions after the date of death, for example. So we were able to clean a lot of things, and I think that's very helpful for our database and for the future studies of CDM. This was really good exercise.
Even though we had our quality checks, OMOP gives you another quality check. So you are looking at your same data with different eyes, and it covers things you weren't aware at first. So for instance, that the zombies, I think Achilles call it, you have people that have a death, and after that you have a surgical procedure, for example. And that kind of data happens on real-world data and administrative data. Sometimes are errors, sometimes are coding differences, but that you can check on. Fortunately, there are not a lot of cases, but they are there, and then you could take a decision to get a full database of very much quality.
Right. So I guess once you map to OMOP and you also run of these Achilles reports to generate quality, you can then run Atlas, which is really the powerhouse of OMOP. So have you already been able to do that?
Yes. We plan to do some kind of demo here, so you can look at the tool, the kinds of data you can.
I think yeah, it would be good to spend a few minutes on that if you have it ready. Sure.
Yeah, maybe we can show as an example that we've tried to create the cohort. One of the cohorts that we created in Oxford, right? The studyathon. I think that can be an example. But first, maybe we can just show this graph here.
Okay, so the first graph I have a zoom of it is the data density graph. The data density graph shows you just by volume in every domain. So you have conditions, deaths, drugs, procedures, and here you can see that also you have drugs by exposure. And I think that it's very good that OMOP produces is the drug eras. It collapses all your different drugs into periods of the same ingredient exposure. So we have here in green the drug exposure, for example. There's a lot of data. There's the majority of data because one people gets one prescription, but then you have many dispensations and it increases the volumes. But when you produce the drug eras, it minimizes the data to the periods of exposure to a single ingredient. That's shown here, and that's the derived tables are drug eras from drug exposure and condition eras from condition occurrences by using an R program to produce them. Then here is our Atlas installation. The thing you can look at these are by your data sources. You can have many. We have the CDF database represented. And when you run the reports, you can look at each of those reports. The first one is a dashboard that shows you the number of people you have there. I don't know if it's showing. Okay, it's very small, but it's 7.5 million patients there. It includes living and death, the distribution by gender, the age of their occurrences that we talked about earlier that people were entering when they were newborn. There's the majority of the people, and then by ages they enter. Another one you can take a look at is the person report that shows you a picture of the people in the database by age, by year of birth, by birth year. You already can see some specificities. That's the 1930s, final 1930s, 1940s civil war, Spanish Civil War, that produces a glitch here in the volume of births.
And maybe as an example, we could show the studyathon cohort that we created.
These same reports that you have for the full database, you can also look at them for the cohorts that you create. So if we look at the studyathon cohort, that's this one. That was the total knee replacement cohort. There's a reporting
for that specific cohort.
In here, since people are entering by the total knee replacement, if you will look at the procedure, for example, for this report, it gives you a tree map, and you can, as you expect, the most frequent is the total knee replacement. So you not only can look at your data, but at that same reports for the cohorts that you create.
So even though we were not didn't participate in the studyathon, we could use that cohort to to see if we were able actually to do this in CDApp, and this was really helpful.
Just we grab the cohort definition and just put it into this JSON definition and hit the run, and the cohort was generated.
Right. Yeah, that's extremely powerful. It always gives me a bit of a chill when you're looking at the actual data. I guess that makes me a data nerd, but really to see for example, the gender distribution, the Civil War effects, etc. It reinforces we're actually looking at data from 7 million people here.
Mm-hmm.
And I think the research definitely shows. We actually are going through our time really quickly, so maybe it's good to spend a few minutes on two more topics. One is anything you would like to share to other data sources that are considering maybe responding to our open call that we have upcoming from EHDEN, or that are looking at mapping to OMOP on their own. And the other topic would be great if you can spend a few minutes on the potential impact of all this. So let's start with the first one. What would your message be to other data sources that are considering EHDEN data partner, or even mapping to OMOP on their own?
Well, what I would say would be, don't think twice. I think it's there are a lot of challenges while doing this, but I think EHDEN is going to provide the right support so you can do that. But there is definitely much more advantages of doing this. We've mentioned some of those, but I think definitely you shouldn't think about and you should do it. For us, we can only see now all the advantages, really how this can be really powerful, not only for your own database, but for research in general. I think that's what motivates us doing this, right? Also, I think you do need to ask for help when needed. I think that was one of the lessons learned here. And also that you need a very multidisciplinary team. With, like in everything that we do, we need to work with people with different backgrounds. In our case, we were lucky to have Leo, who, he's a medical doctor. He's an expert in also IT. And I think we were really lucky, and he knows very well the source data. I think that was also, I think you need to have somebody in your team who really knows the source data, where this data is coming from before going into the CDM. And also you need to work with people who understands the CDM as well, so OMOP experts. I think
one take-home message that I can give for people trying to do this journey is that as an ETLer or as just deploying the tools, is that have your tool your tool chain in place earlier. As soon as you can. So you can be doing the mapping, and then you can get immediate feedback from the atlas, for example. So you can have already the things that are with warnings, and you can act quickly on those, rather than trying to put in everything at first and then use the tools. That's one big learning for us.
Yeah, and do have different people being able to do this in your team, because in our case, Leo, he's our guy, but he broke his leg. Several things happened on the ways, and then we were like a bit stuck.
I became father.
He became father. Yeah, all those things happened while he was doing the mapping. So yeah, it is important that you have a team of people working on this.
And the other one is to lean on the community. There's a big community that are very kind and very forward going, and they can help you in each of the steps.
Right. Okay. So yeah, we have a recommendation here to go forward with OMOP, but also some reminders that you really do need a multidisciplinary team, and don't be afraid to ask for help. So our last few minutes, I mean, if there are any questions from the audience, I think we're happy to take them. Please type them into the question and answer box, and we will see them. If there are no questions on this, maybe we can spend a minute on the impact of all this. So as I said, you sent me a study last week, which was about statin prescriptions in GPs. I think this is a very relevant question. You know, day to day, if you go to your GP with a health problem, you'd hope that he's sort of up to speed with the latest research on this. From your perspective, how does all what you're doing, you know, CDR, but also the mapping to OMOP, in the end benefit the people of Catalonia?
Well, I think one of the advantages is obviously we will be able to run studies much faster, but also in a community with other databases, including different populations. And I think that's definitely a benefit for research in general. I don't know if you want to add anything.
One specificity of CDR database is that it works very closely with Catalan Health Institute. So we can lean on the discoveries that CDR database research does and give it back to the clinical health record. We can, for example, dream of putting prediction tools in the clinical health record. That's one of the things that's doable.
Yeah, that's a good thing, because since we work very closely with the main health provider, with the people who actually develop the ECAP software, which you know, health professionals are using, it's easier then to maybe use some of the things that the results that we are getting in our projects, or if we develop new patient level prediction modeling, you know, how can we include that in a patient electronic health record? Since we work really closely with the Catalan Health Institute, I think that's possible here, and it's possible to give feedback to GPs and to people through GPs. Actually, I think that's a big advantage of what we do.
Another possibility is since you have all these processes streamlining the research, you can lower the barriers, so new people, like for example GPs, can start thinking of answering the clinical questions if you somehow put this available to them.
I think also for security, you know, when you think about how the projects work within the Odyssey, that we will still have our data here, but we can run studies with other databases across the world. So also thinking about, for example, rare diseases where sometimes we don't have enough numbers to look and to study those diseases. If we are able to run a study in collaboration with colleagues in Korea, in the US, in Africa, I think that is really powerful for you know, for research and for the people living in Catalonia.
The directed aspect of this platform, that analysis come to data and data don't have to move to other researchers. That's very powerful.
Yes, definitely looking forward to be able to perform the first studies in the EHDEN network. It will take a few years, but on the other hand, we may have some early successes because it sounds like you are preparing for OMOP CDM, and so are a lot of other health data sources. What is your perspective currently in Europe? I mean, you must meet other databases. I think you're in a number of networks like EHDR, and you meet them at conferences. So your view on sort of the uptake of OMOP?
The uptake? Well, I'm very hopeful that people jump in and increase this the quantity and quality of the data that are mapped and standardized, so research can be more, not just statistical powerful, but more representative of the European community, in order to answer questions, real questions that are asked and need this kind of big data sources for research.
Yeah, I think at the end of the day, we are all doing this for a purpose, and I like to think that as researchers, you know, we all have a goal, which is, you know, have an impact and improve people's health, and I think we have the responsibility of doing this together. You know, there's no point of doing trying to answer the same question here and someone else being in the UK trying to answer the same question. I think that's not.
And you can collaborate.
Yeah, I think EHDEN is gonna help us, getting together as a community and performing and answering the same questions together.
Right. Okay. So the very last round, if there's any questions from the audience, we can take them in this last minute. Otherwise, I mean, I have a lot of questions, but I think those are for another time. Sorry, I'm just getting something from the tech team here.
Mm-hmm.
So the question seems to be about the duration of how long does it take to convert your data to OMOP? Could you comment on that?
Yes.
That's a difficult question because of the circumstances we had, but yeah, Leo can go ahead.
Well, yes. Apart from personal circumstances of the mapping team, the thing is, it depends a lot of the kind of data you have. You have data that already uses international codes. They're a big help with the vocabulary because most of the vocabularies are there in the OMOP. You can download it from Athena. There are, I don't know how many, but more than 40 vocabularies there. So chances are your data, if you're using a standard, is already easier to map. The other is the provenance of data. You have data from just primary care and from just one clinical health record system is easier than if you try to put in there also hospital data or dispensation pharmacy data. So it all depends. In our case, it took, if we take apart the time from the sick leaves, maybe it took like between 12 months or 15 months just to get to a complete scenario where you have the tools deployed and you have the main domains represented in the mapping.
Yeah, so it also depends on the amount of people that you get working on the mapping. Yeah.
Maybe you can measure it in person time. I think there was some experiences from the States, from the United States. There were, I think I found an article there. I don't remember how much it took, but they have the numbers for was the dedication for mapping one source.
Right. Okay. So thank you very much, Talita and Leo, for joining on this third EHDEN webinar.
Thank you. It's been a pleasure for us.
Yes, we will for sure have more webinars. So for audience, please stay tuned and watch the website and our IMI EHDEN Twitter account. Thank you so much for joining us today. Goodbye.
Thank you. Bye.